Kharkiv National University in Ukraine. Dr. Tetiana, are you there with us?
Good afternoon, everyone. 1 second, I will try to share my screen. Is it visible now?
Yes, it is visible.
Okay. Is it correct now?
Yes, you can begin.
Okay, thank you. Good afternoon, everyone. I'm thankful to be here with you today. And let's talk about the topic of my presentation, morphofunctional features of the ventricle of the heart in children with juvenile idiopathic arthritis. Who I am? My name is Tetiana Holovko. I'm living in Kharkiv, which is located in east part of the Ukraine. And I'm working as a doctor and as a scientist in the scientific university in the Kharkiv, and I'm working as an associate professor of the pediatric department of the medical school in Karazin University. Despite the war, which is still going in our country, we are working and providing our research. And I will present to you results of our research, which we are doing in our department. I have no relevant financial interest to disclose. What means the juvenile idiopathic arthritis? It is the most common chronic inflammatory autoimmune disease in childhood. It is an umbrella term for arthritis of unknown origin, which lasts more than 6 weeks with onset before 16 years of age. Globally, approximately 3 million children and young adults are estimated to suffer from juvenile idiopathic arthritis. The global prevalence of juvenile idiopathic arthritis has been estimated to range from 3.8 to 400 by 100,000, with an incidence of 1.6 to 23/100,000. Girls were consistently found to be at a higher risk than boys, and oligarticular subtype was found to be predominant. In our work, we are using classification which created by International League of Association for Rheumatology, and this classification includes 7 subforms. It's oligoarticular subform, it's polyarticular subform, which divided on the RF negative variant and RF positive type. It's a systemic juvenile idiopathic arthritis, it's a psoriatic arthritis, enterocyte-related arthritis, and undifferentiated subform. On this slide, I present a table which shows for us some characteristic of different subforms of juvenile idiopathic arthritis. And last line shows for us which disease equivalent will be in adulthood in our patients. As we know, in many cases, adult patients with rheumatoid arthritis develop comorbid diseases against the background of the main process, which significantly complicates the patient's condition and worsens his quality of life. Most often, this category of patients develop cardiovascular disease, that leads to the development of severe complications and to the heart failure formation. It has been proven that even in the period of clinical remission of rheumatoid arthritis, subclinical inflammation remains, and evidenced by an increase in the level of inflammatory cytokines, endothelial dysfunction, and activation of markers of oxidative stress and adipokines, which in turn support the process of vascular remodeling. Heart failure, it is a clinical syndrome which characterized by violation of the pumping function of the heart, decrease in tolerance to the physical activity, fluid retention in the body, progressive course, and bad prognosis. For pathogenesis of heart failure, very specific reduction of cardiac output, first of all. It leads to the reduction of stroke volume and elevation of heart rate. On this background, activation of sympathetic system appear, and it leads to the high production of catecholamines and vasoconstriction. Due to vasoconstriction, go further step, poor circulation of kidney, and due to this reason, activation of renin, angiotensin, aldosterone system. This activation leads to fluid retention and to the progression of heart failure. For our work, we are using two variants of classification of heart failure. One of them, it's a classification from American colleagues of Cardiology Foundation, and this classification based on the structural heart diseases. And second one, it's a New York Heart Association classification or functional classification, which based on the patient's feeling on the limitation of physical activity. So the aim of our study was to determine morphofunctional features of right ventricle of the heart in adolescents with juvenile idiopathic arthritis with long-term basic therapy. As known, there is an intraventricular balance in the heart. If one ventricle has some problem in work, other one helps it, but it can't last forever. But during routine investigation, usually doctors focused their attention to the left part of the heart, and usually miss functional condition and structure parameters of the right heart. That's why we focused our study on the both ventricles, left and right. In our research, we investigated 91 patients with juvenile idiopathic arthritis who has polyarticular form of juvenile idiopathic arthritis. Average age of these patients was around 13 years. In this group, predominantly were girls, it's 77%, and quarter of them were boys. All parameters of the sick patient, of our patients, we compared with healthy peers who were in age around 14 years. It was control group, and it's included 45 healthy adolescents. And predominantly it were also girls, 64%. All patients with juvenile idiopathic arthritis got basic therapy with methotrexate. The average dose of this drug was around 12.5 milligram per square meter per week. The duration of the disease in these patients was around 45 months. We did ultrasound examination for all these patients and healthy adolescents and investigated structural and volumetric parameters of the left ventricle, of the right ventricle, and functional parameters, both cavities. And also we taken in account heart rate of these patients. First of all, we analyzed structural and volumetric parameters of left ventricle of the heart, and we got that end diastolic volume of left ventricle was significantly lower than in healthy teenagers. Ejection fraction of left ventricle also was lower, and a stroke volume of left ventricle also reduced in patients with juvenile idiopathic arthritis. All these changes happened on the background of elevation of heart rate. During analysis of structural and volumetric parameters of right ventricles, we find out that end systolic and end diastolic sizes, end systolic and end diastolic volumes of right ventricle were significantly more than in patients in healthy teenagers. But functional parameters have changed in other way. Ejection fraction of right ventricle reduced, but systolic stroke volume and minute volume of right ventricle were significantly higher than in healthy teenagers. Next, we identified two groups from the patients with juvenile idiopathic arthritis. First group included 19 patients, and these patients had ejection fraction of left ventricle less than 63%. Second group included 22 patients, and these patients had ejection fraction of left ventricle on the higher level, more than 68%. And what we got? In patients with lower ejection fraction of left ventricle, in same time reduced stroke volume of left ventricle, but from structure parameters, elevated and systolic and diastolic sizes of left ventricle, myocardial thickness was more, intraventricular myocardial thickness was more than in opposite group, and systolic and diastolic sizes of right ventricle also elevated. From volumetric parameters in patients with lower ejection fraction of left ventricles, and systolic and diastolic volumes of left ventricle elevated, and systolic and diastolic volumes of right ventricle also elevated. Next, our decision was to identify two groups according to the level of ejection fraction of right ventricle. And we created group with a low level of ejection fraction of right ventricle. This group included 10 patients. And opposite group was with a high level of ejection fraction of right ventricle. This group also included 10 patients. What result we got? In patients with a reduction of ejection fraction of right ventricle, we got a reduction of stroke volume of this cavity. Also, and systolic volume of right ventricle were high, and systolic and diastolic left volume of left ventricle were high. From structural parameters, have changed and systolic and diastolic sizes of left ventricle. These parameters were significantly higher than in patients with high ejection fraction of right ventricle. Thus, an increase in both systolic and diastolic parameters of the right ventricle of the heart, with a decrease in ejection fraction and an increase in stroke volume and higher heart rate and minute volume in adolescents with juvenile idiopathic arthritis was found. These changes may indicate heart myocardium remodeling to maintain its functional state. It's clear that it's not always necessary to provide ultrasound in such details every single time. That's why in this slide I want to send you the main message of our report. In patients with juvenile idiopathic arthritis, not only joints are involved in the pathological process, but also inner organ and systems. The cardiovascular system monitoring in patients with juvenile idiopathic arthritis is required. Due to our study, heart ultrasound should be performed every 6 months in these patients. Both ventricles, left and right, must be examined during the heart ultrasound. Thank you for your attention. You are free to ask any question if you have it.
Thank you.